Welcome to This Explainer. Okay, today we're going to dive straight into the fascinating science of addiction. We'll be looking at substance use and related disorders, but through a rigorous clinical taxonomy. So we're not just looking at the substances themselves, right? We're going to explore their exact pathophysiology, the diagnostic criteria, and the precise clinical management to really understand how these disorders operate both neurologically and physically. It's like looking under the hood of addiction. Let's get to it.
Here's our roadmap for today. We'll start with the foundations of substance disorders, then move on to alcohol and sedative hypnotics, followed by stimulants, hallucinogens, and cannabis, and finally, we'll wrap up with opioids.
Section 1. Let's lay the groundwork with the foundations of substance disorders, focusing on diagnostic criteria and testing.
So, in clinical medicine, we rely heavily on the DSM-5 criteria to actually diagnose a substance use disorder, or SUD. The whole diagnosis really hinges on a problematic pattern of use that causes significant impairment or distress. Specifically, we're looking for at least 2 symptoms within a pretty rigid 12-month period. Now, these symptoms aren't just about how much someone is using. It's more about intense cravings, that persistent desire to use, maybe failing to fulfill major obligations at work or at home, and, this is key, continued use despite glaring physical or social harm. We also grade the severity based on the sheer number of symptoms. Mild is 2 to 3 symptoms, moderate is 4 to 5, and severe is 6 or more. This strict framework is absolutely crucial. Why? Because it helps clinicians separate casual, non-problematic use from a true physically and socially destructive clinical disorder.
Now, 2 of the absolute most critical physiological criteria in the DSM-5 are tolerance and withdrawal. And it's really helpful to separate how these 2 phenomena actually operate in the body. Tolerance is basically a neurobiological adaptation. It's when a patient requires increasingly higher amounts of a substance just to achieve that same desired effect, or they get diminished effects from the exact same dose. Withdrawal, on the flip side, is a very substance-specific physiological syndrome. It's the body aggressively reacting when a patient stops or even just reduces prolonged heavy use. Really, these twin phenomena form the core physiological engine of so many substance use disorders.
Let's talk testing. There are vast pharmacokinetic differences in metabolic detection windows across these different drug classes. Just look at how rapidly alcohol is cleared from the system. We're talking often within just a few short hours. That makes blood or urine testing for alcohol highly time-sensitive. But contrast that with marijuana. Because of its lipophilic nature, the detection window stretches from maybe 3 days for a single use all the way up to 4 weeks for heavy users. That's a huge difference. Also, it's worth noting that standard opioid screens typically just detect the morphine metabolite over 1 to 3 days. So what does that mean? It means synthetic opioids like fentanyl actually require completely separate, specific assays.
Okay, so when we move from diagnosis to behavioral counseling and psychosocial treatment, think cognitive behavioral therapy, we really have to understand the patient's psychological progression. And we map this out using the 6 stages of change. It starts with pre-contemplation, which is basically where the patient doesn't even view their addiction as a problem yet. Then we move into contemplation. They're starting to think about stopping. That's followed by preparation, action, and maintenance. And here's the really important part. We must clinically recognize relapse as a formal stage in the cycle. It's not necessarily a failure of treatment, guys. It's actually an expected part of the behavioral journey.
Moving right along to Section 2, alcohol and sedative hypnotics, where we'll look at their pathophysiology and clinical presentation.
When you're assessing a patient for alcohol use disorder, this specific ratio right here is a massive clinical red flag. We often see elevated liver transaminases, sure, but specifically an AST to ALT ratio of 2 to 1 or greater, that is a very strong indicator of alcohol misuse. You'll also frequently spot an increased mean corpuscular volume, or MCV, in up to 95% of these patients, plus you'll see elevated GGT levels. Actually, GGT is one of the very earliest signs of alcohol-induced hepatic stress. It's an incredible biomarker.
Let's break down the exact mechanism. Alcohol is a remarkably potent central nervous system depressant. It works by activating GABA, which is our primary inhibitory neurotransmitter, while simultaneously hitting the brakes on glutamate, our primary excitatory neurotransmitter. Then it's metabolized in the liver via a 2-step process involving the enzyme aldehyde dehydrogenases. Clinically speaking, intoxication scales directly with blood alcohol levels. So at 20 to 50 milligrams per deciliter, you'll start to see impaired fine motor control. Push that to between 50 and 150, and you're looking at impaired judgment and an ataxic or stumbling gait. Once you push past 150 up to 300 and beyond, you are looking at profound lethargy, severe memory issues, and even coma, especially in novice drinkers who haven't built up a tolerance.
Now, what's really interesting and dangerous about this is what happens when a dependent patient stops drinking. There is a highly predictable chronological onset of withdrawal symptoms. From 6 to 36 hours out, you see minor withdrawal, tremulousness, maybe some mild anxiety and GI upset. Between 12 to 48 hours, the risk of seizures and alcoholic hallucinosis actually peaks, though interestingly, their vital signs usually remain normal. But the true clinical emergency, that hits between 2 to 4 days. Delirium tremens. This involves severe confusion, profound agitation, and really dangerous vital sign instability. And we have to take it seriously because it carries a daunting 5% mortality rate.
Another major complication of chronic alcohol use is vitamin B1 or thiamine deficiency. And this presents in two distinct phases. First, there's Wernicke's encephalopathy. This is the acute, reversible phase characterized by a classic triad: broad-based ataxia, confusion, and ocular abnormalities like nystagmus. Now, a critical, absolutely crucial rule in clinical medicine here: parenteral B1 must be administered before giving glucose, or the condition will rapidly worsen. If Wernicke's is left untreated, it progresses into Korsakoff syndrome. That's a chronic, permanent amnestic disorder where patients suffer from anterograde amnesia, meaning they can't form new memories. They unconsciously make up answers just to fill in those memory gaps, which is a fascinating yet tragic symptom known as confabulation.
Grouped closely with alcohol are the other sedative hypnotics, primarily benzodiazepines and GHB. Much like alcohol, these agents potentiate the effects of GABA by modulating GABA-A receptors. So as you'd guess, intoxication looks very similar: drowsiness, ataxia, and potentially fatal respiratory depression. In the event of a severe benzo overdose, the specific pharmacological antidote is flumazenil, which is administered alongside basic airway support. GHB operates similarly as a CNS depressant, but is dangerously notorious as a date rape drug. One major takeaway here: if you're withdrawing a patient from these sedatives, it requires a very, very gradual benzodiazepine taper. You can't just stop cold turkey, or you risk life-threatening seizures.
All right, Section 3. Let's switch gears and talk about stimulants, running from cocaine all the way to nicotine.
When we compare the pathophysiological mechanisms of major illicit stimulants, we actually see some distinct, fascinating differences. Cocaine exerts its effects purely by blocking the synaptic reuptake of dopamine, epinephrine, and norepinephrine. It essentially traps them in the synapse, flooding the brain with these excitatory neurotransmitters. Amphetamines, however, they're a step more aggressive. Classic amphetamines, like meth, not only block that reuptake, but they also actively facilitate the release of extra dopamine and norepinephrine from the presynaptic neuron. And then you have substituted amphetamines, like MDMA or ecstasy, which add a whole third layer by also causing a massive release of serotonin.
Because of those intense mechanisms, the clinical presentation of stimulant intoxication and withdrawal are basically physiological opposites. Intoxication results in extreme euphoria, dramatically dilated pupils, tachycardia, and a very real dangerous risk of cardiac arrhythmias, hyperthermia, and even heart attacks. Conversely, withdrawal triggers a severe crash. We're talking prolonged depression, intense cravings, and severe lethargy. Now, here is a massive clinical warning for you. When managing stimulant intoxication, you must absolutely avoid administering beta blockers. Doing so can lead to unopposed alpha-adrenergic receptor stimulation, which causes severe refractory hypertension. Just don't do it.
Nicotine is another incredibly powerful stimulant. It stimulates nicotinic cholinergic receptors, which then directly triggers the brain's dopaminergic reward system. That's exactly what makes it so profoundly addictive. Withdrawal is rapid, usually peaking within just 24 hours, and it presents as intense cravings, irritability, and weight gain. But fortunately, we have some really precise pharmacological interventions for this. Varenicline acts as a partial agonist at those specific nicotinic receptors, basically tricking the brain to ease those cravings. Then there's propropion, an antidepressant that inhibits dopamine and norepinephrine reuptake, which helps blunt the withdrawal symptoms, usually prescribed right alongside your traditional nicotine replacement therapies.
Moving on to Section 4, let's explore hallucinogens, PCP, and cannabis.
Academically, we have to clearly separate dissociatives from classic hallucinogens. PCP and ketamine are your dissociatives. They act as NMDA glutamate receptor antagonists. Intoxication here is incredibly volatile. You'll see severe agitation, synesthesia, like tasting colors or hearing shapes, rotary nystagmus, and heavy muscle rigidity. Classic hallucinogens like LSD and psilocybin, however, act primarily on the serotonergic system. They cause intense perceptual changes, highly labile affect, and sometimes extreme panic, which people call a bad trip. But noticeably, despite all their wild differences, neither class actually produces a formal physical withdrawal syndrome, although long-term users can definitely experience spontaneous flashbacks later in life.
When looking at cannabis, it's super important to view its clinical profile objectively. The main psychoactive component is, of course, THC. Intoxication commonly features euphoria, altered time perception, and conjunctival injection, red eyes. And it certainly has proven legitimate medical utility. It treats chemotherapy-induced nausea, chronic pain, and even lowers intraocular pressure in glaucoma. However, the withdrawal is very real. It can present as anxiety, insomnia, and aggression. And most concerningly, there's a severe psychiatric risk. Cannabis-induced psychotic disorders occur in roughly 10% of overall users, but that risk literally skyrockets to up to 50% in heavy, daily users.
Finally, Section 5, opioids. Let's dig into their pathophysiology and management.
So the crucial point here is to commit the classic opioid intoxication triad to memory: profound respiratory depression, an altered mental status, and meiosis, which means pinpoint pupils. While the intoxication itself suppresses the CNS, it's actually the respiratory depression that causes fatalities. It's what stops the breathing. Now, opioid withdrawal, much like with stimulants, presents as the exact physiological opposite. You see intense dysphoria, piloerection, literally goosebumps, which, by the way, is exactly where the phrase cold turkey comes from, along with fever, diarrhea, and widely dilated pupils. We typically manage this massive autonomic storm with clonidine and other symptom-specific medications.
Our pharmacological toolkit for managing opioids is incredibly specific, and it's a real game changer. For an acute overdose, naloxone is your immediate antidote, though it will rapidly precipitate withdrawal, so you have to be prepared for that. For long-term management post-withdrawal, we often use methadone. That's a full mu receptor agonist with a very long half-life, though we do have to monitor patients closely for QTc prolongation on an EKG. Buprenorphine is a partial agonist offering a substantially safer profile than methadone. And finally, naltrexone is a competitive opioid antagonist. We use this in highly motivated patients to actively reduce cravings, though it does carry a slight risk of elevating liver function tests.
We have covered an immense amount of ground today, seeing exactly how these different chemical classes completely hijack the brain circuitry. So, given these profound, long-lasting neurological adaptations we've talked about, how can clinical medicine continue to evolve? How do we move beyond merely managing acute withdrawal to truly ensuring long-term structural neurobiological recovery? That is the ultimate question for the future of addiction medicine. Thank you so much for exploring this with me in this explainer. Keep asking great questions, and I'll see you next time.